CataractCoach.com. Quiz time. When did the posterior capsule break? Watch the video carefully and let's figure this out together. Our guest here is Dr. Lukan Mishev from Bulgaria, a fantastic surgeon. Love to watch him operate. He does all kinds of cases. Cataract, posterior segment, glaucoma, cornea, you name it. So let's see what he's got going on here. He's got his own design of a chopper too, by the way. So buzzing in with a phaco probe, chopper going around the equator. There's a nice horizontal chop, beautifully done. So you can obviously tell by the video, he's an expert surgeon. He is also incredibly smart when it comes to using these digital filters. He is really setting the standard here for using different filters to improve the view or visualization during surgery. So now that he's using this heads-up display, looks like the Ingenuity system, he has developed his own digital filters that he can use to increase contrast, increase visibility, etc. during surgeries, both anterior and posterior segment surgeries. So you can see he's making short work of the cataract. This is a video shown in real time here. Everything goes great, but you saw the title slide. We're going to end up with a pop or a hole in that capsule, and we got to figure out when it happens. So watch carefully. I mean, so far so good. Now this part's pretty easy because you have that last nuclear piece weighing down the capsular bag. So the capsular bag is not going to flop around at all. Looks like very good stable fluidics too. And so now he's rotating that last piece around. It looks like it goes pretty well. There's the last piece. Coming in with the phaco probe, chopper again, and splitting it maybe and bring the pieces up. Again, watching very carefully. Let's look there. It looks good. Very stable fluidics. Look at the settings that are appropriate. Flow's not too high. I use a very high flow, but his flow is very reasonable. Only less than 10 cc's, 20 cc's a minute. So a very reasonable flow here. And the last piece is coming up. And watch carefully. And here it comes, last piece. And he comes out of the, and he knows instantly. See the particles coming up? And he switches his filter. This is one of his built-in filters. He switches on his foot pedal. Now, hopefully that anterior hyaloid face is still intact. But you can see there's a round hole that developed. So my guess is it probably happened when that last piece came out, that floppy posterior capsule came up towards that phaco tip and just touched it, and then there you go. So now using infusion in the eye, and sometimes you don't realize this until you just come out of the eye. Ideally, you don't come out of the eye, and if you notice you have a break there. So he's come out of the eye, infusion in the right hand, left hand's injecting viscoelastic. There we go, plenty of viscoelastic, and there's that break there. Now, it's nice and round and continuous, and it's not going to run out anymore. So that's reasonably strong as it is. The question is, do you have any prolapse of vitreous? And now, what are you going to do for the lens? Well, with a hole that's relatively small like that and central, you probably just still put the lens in the capsular bag. It may not even change the choice of lens you're going to do in this case. So this just shows you, this is a very experienced surgeon. Tens of thousands of cases. He has a great YouTube channel, which you should definitely check out. He even does live surgery on his YouTube channel. He live streams surgery. So you can watch him do it live. So here comes our lens. Yeah, it looks like a single piece acrylic lens. He's putting that into the injector. You're going to put that inside the eye. And so, yeah, undoubtedly, that style lens you're going to put right inside the capsular bag. And so he'll deliver that lens here in the bag. But yeah, this is kind of a complication that can happen to anyone at any time. And this is why, we really have to be vigilant during surgery and then be able to handle anything. So here comes the lens, fixating the eye with that second instrument. Here comes the lens through the incision. And now carefully going to guide that into the capsular bag. Very nice. Probably going to use that second instrument too to help dial it in. Yep, here it comes. And get that in the capsular bag. Not too much manipulation. You want to be nice and gentle on that. Don't want that posterior hole to get enlarged at all. And that looks good. It looks like this lens has some sort of central focusing element on it maybe too. Maybe it's some sort of EDOF lens or very interesting. There we go. So now you got to remove viscoelastic. And the question is, when you remove this viscoelastic right now, are you going to go behind the IOL optic or not? What are you going to do? So there's the eye probe, and the left hand is the aspirator. So notice how he's got the lens in first to cover up that hole with the optic before going in there and getting all that cortex out. Notice how he didn't try to get the cortex out. He put the lens in first because there really wasn't too much cortex. But now, using that bimanual IA set, you can really get in there in the capsular fornices or in the lens, near the lens bag equator and get out that cortex that's remaining. Just being very careful the entire time doing this, watching that central hole, making sure it doesn't expand anymore. Because right now, the lens has very good stability, and you kind of want to keep it that way. You want to be very cautious here. And so do you go behind the lens? I probably would not. I'd do as much as I can in front of the lens, and right here, like he's doing in the capsule bag equator, is fine. But I'd probably just watch the patient's pressure in the post-op period. I'd be too cautious here because I don't want to. I'd be afraid of upsetting that anterior hyaloid face and causing a break there. Because at this point, look, the lens is beautifully centered, no issues at all. I don't think there's any vitreous prolapse whatsoever, and this patient can have just a beautiful, beautiful outcome. And so he did not go behind the lens to remove the viscoelastic, which I think is totally reasonable. I would not have done so either. Now he's sealing up this paracentesis while the right hand maintains infusion. Look at that. Don't let the AC collapse. What a great lesson there. And now look, hydrate the main incision too while not letting the AC collapse. That is such an important rule there. Now you can come out of the eye. Look, the AC is still maintained. Hydrate up the other paracentesis. This patient had a beautiful outcome. So remember, complications happen to everyone. If someone says they don't have any complications, either they don't operate or they're not truthful. Even absolute experts like this can have a complication every once in a while. But the difference is an expert like this can recover and have a beautiful outcome.